I will talk this morning about heart team-related concepts regarding the coronary patient. Okay, it's working. I have no conflict of interest. The learning objectives of the session will be to define the roles of the heart team for coronary patients, to review the different scores for risk stratification, and finally to review the revascularization options for complex CAD and unprotected left main disease. So I have to admit that when Philippe asked me to talk about heart team for CAD, I didn't quite know where to start. And I was searching for some inspiring work team in general. And as a Montreal Canadian were not that inspiring this year, I had to search for somewhere else. And I was reading a book at that time, the Steve Jobs books, and it's still not working. And it's interesting in the book, somewhere in the book, he says about his success in business, that great things in business are never done by one person. They're done by a team of people. And it becomes even more interesting later on in the book when it starts to describe his medical treatment that he had when he was sick. He said, I realized that I was facing the type of problem with my oncology care that I never permitted at Apple. My treatment was fragmented rather than integrated. I was being treated by oncologists, pain specialists, nutritionists, hepatologists, hematologists, but not being coordinated in a cohesive way. So being Steve Jobs, he decided to reunite all those doctors from Stanford at his house to coordinate his treatment, and that's what it is to have a medical team to treat the patient, so working together to offer the best treatment. So there are obviously well-recognized type of heart teams: heart transplantation, mechanical heart failure clinics, transcatheter valve programs. However, where do we stand for CAD patient? And I would be interested to see by a show of hands how many of you have a dedicated heart team for CAD patient in your hospital. So maybe in the panel, there's one hand up there. So half, one and a half. Okay, in my hospital, we do not have a well-dedicated heart team. So the heart team approach in CAD was introduced with the Syntax trial in 2005, where more than 4,000 patients were screened by both a cardiologist and a surgeon to evaluate the inclusion criteria for the patient. And since then, other trials have also included heart team discussion to randomize their patients. So it is there for sure. But why do we need a heart team approach for CAD? We like guidelines, and there are a lot out there. So as the literature in cardiology is exploding, we have more knowledge in a group than as an individual. And you can see for the last 2 decades, the augmentation of publication only in the US. For the year of 2013, more than 7,000 publications were produced. That's a lot to read for an individual. And there are the risk score that were part of those publications that are very important. They're essential for objective risk stratification. They were developed for surgery or angioplasty, and they were validated in large studies and registry. However, there are weaknesses associated with each of them, but they play a key role in the patient risk evaluation by the heart team. If we go back in time, the Parsonet score that was one of the first ones to be used in 1989, still a good score. It's simple. It's an additive score. However, it tends to overpredict mortality right now these days. The STS score was introduced in 2007. It's a surgical score, obviously. It's also a simple additive scoring system. It is more detailed than the Euro score, and you can also obtain risk stratification for morbidity and mortality, especially for CABG surgery. However, it tends to underestimate the surgical risk. The Euro score was introduced in 1999. It is also a simple score, an additive score, well validated, but it will overpredict mortality. The Euroscore logistic that was developed after that is a lot more complex and will also overpredict mortality, especially in high-risk patients. Finally, the Euroscore 2 that was introduced in 2012, which is a score that emerged from the Euroscore, the original Euroscore, include other variables like poor mobility to better define the risk. And it's a better tool compared with the other two Euroscores. Finally, the syntax score introduced in 2005 for us cardiologists. That was validated in many studies, like the syntax trial. It is purely an angiographic scoring system. It has no clinical data included, and the score can range from 0 to 83 points. You can divide the score in three terciles for low, intermediate, and high-risk angioplasty patient. The syntax score will predict MACE, not only mortality, post-PCI. However, as you all know, there are no correlations with MACE post-CABG. One of the problems with the syntax score is that there is a high inter and intra-observer variability. In that study reported a few years ago, when we compared the core lab versus size-reported syntax score, we realized that in only 5% of the cases, both scores were the same. In more than 95%, you either had an overestimated score or an underestimated score by the site. So working as a team would definitely help to normalize those estimates. The syntax score has evolved a lot during the past few years, always trying to implant clinics into the score itself. The global risk syntax score has been used a lot, and there is now the syntax score 2 that is coming out and seems to be an interesting tool to predict. So it was introduced in 2013 and validated in the big Delta registry. The syntax score 2 will combine the anatomical syntax score with the presence or absence of left main disease with 6 clinical variables: age, gender, creatinine, PVD, COPD, and left ventricular ejection fraction. It is designed to discriminate between CABG and PCI interactions. And you can see in those graphs the interaction for all the data between PCI and CABG. And one interesting thing here in the left lower panel is that with diabetes, there was no interaction. So diabetes is not included in the syntax score 2. So when you calculate your syntax score 2, you will use that nomogram, and now there is an online calculator available since last month, and it will give you a 4-year mortality risk for both CABG and PCI. It will help you to decide which way your patient should go. So it is more an individualized approach to help you identify a subset of patients in the 3 syntax tercile that will have a lower, similar, or higher predicted 4-year mortality with either CABG or PCI. Why do we need a heart team approach? We need to share experience, specific expertise. There are new scales out there, the frailty index, for example, that we don't quite know how to use. We saw yesterday all the new technology with surgery. There are more sophisticated PCI techniques. For example, that RCA shot a few years ago, even a non-selective shot of that artery would have been enough to stop the case. However, these days, with complex angioplasty techniques, you can then end up with a very nice result. Donc, we need to look at those angiograms in a different ways. Finally, we need the heart team for CAD to share the burden of difficult decisions and potentially to share the liability involved with some of the complications that could occur. Patient involvement will definitely be better, and you might increase trial recruitment using that approach. Finally, you want to offer the best treatment option to your patient. Do we have any proof that it is working in a randomized trial? No, we don't. We still need to demonstrate that in randomized controlled trial, but we have to admit that it makes sense. But some are saying that it is good, but it is time-consuming. It delays decisions, there's a lack of rewards, there is inadequate infrastructures that's not useful in the majority of cases, you have to deal with others' ego, and let's face it, when we are not in the cath lab pushing balloons and stents, well, we like to do something else, and as the surgeon do too. So there's still a culture to develop to really implant the heart team for CAD patient. However, it is in the guidelines. Those are the AHA guidelines from 2011, and it's well written. It's a Class A, Level C of evidence. The usage of STS and syntax scores is also a 2B, Class B, Level B of evidence in the guidelines. The same is true for the ESC guidelines. I can switch it. Thank you. The ESC guideline says the same thing as the CCS guideline. So it is there, and it is well written in the guidelines. Let's surf on the literature now, how to revascularize those patients. So when you look at the 5-year follow-up of the syntax trial for left main disease, if you have a low or intermediate risk, the outcome at 5 years are the same for PCI and CABG. So it's still holding after 5 years. However, for the higher risk group, 33 and over of syntax score, the outcome is better with CABG. So the recommendation in the AHA guidelines from 2011, the only Class 1 indication for left main revasc is still CABG. You have a 2-way indication for PCI if you have both a high-risk patient for surgery or a syntax score of in the lower risk range. And it's a 2B indication if your patient is a high risk for surgery and a syntax score in the high range, in the intermediate range. PCI for STEMI, when the left main is involved, it's a 2B indication. It's written that it's unreasonable to open the left main. I think it's more than reasonable. However, that's how it is written. If the TIMI flow is less than 3, and if the surgery cannot be performed as fast as PCI, which is always the case. The ESC guidelines are more aggressive. For left main angioplasty and the low syntax score, it is a Class 1 indication like CABG. It becomes a Class 2A indication if it's in the intermediate zone, and a Class 3 indication for the higher risk. For trivascular disease now, again, going back to the syntax trial, the 5-year follow-up, if your patient is in the low risk range with a trivascular disease, the outcome is the same after 5 years, so it's still holding. However, if you're in the intermediate range or in the high risk group, the results are better with CABG at 5 years than with PCI. And for the intermediate range, it is new data. At 3 years, it was the same. So the guidelines for multivessel disease, the EHA states that it is with a complex trivascular disease with a syntax score of more than 22, CABG should be preferred over surgery. The ESC guidelines are more specific, and they state that if you have a trivascular disease with a low syntax score, Class 1 indication for both PCI and CABG. If it is in the intermediate or the high risk end, however, it's a Class 3 indication. So in conclusion, building a heart team is mandatory, not only for transcatheter valve program, but also for complex CAD. The syntax score associated with the Euroscore 2 or the new syntax score 2 will help define the most appropriate treatment for your patient. Clinical judgment, however, remains the cornerstone of any decision-making, and we have to wonder if any ad hoc PCI for unprotected left main or complex CD should ever be performed. And finally, remember, you're smarter as a team than you are alone. However, be sure to choose your team well. Thank you, and have a nice coronary day.